Hello, welcome again to another edition of Matters of the Heart, brought to you by Haverhill Community Television and Pentucket Medical Associates. I'm Dr. Seth Bilazarian, a cardiologist with PMA, and I'm with one of my associates, Dr. Sangeeta Nadkarni, a nephrologist with our group, who I've asked to join us on short notice, and she's graciously agreed to join me for a topic that I really was hoping to bring to our audience for some time, and that's a topic of chronic renal failure or kidney dysfunction that happens over time. And I wanted to have a discussion with her to introduce our audience to this topic so that they will be well versed in it, so when they meet with their own doctors can understand the issue about the kidney diseases, and what we can do to prevent kidney problems. So, Dr. Nadkarni, thanks for joining me. Okay. Let me just start by asking you some general questions about it for our audience. So sure. Just briefly tell me, what is the kidney? I think our patients know about their different organs. They've all heard about a heart, a kidney, a liver. Sure. I think some people confuse the kidney and the liver. Tell us what the kidney does, what we can understand about it. And let me just say that actually I should have introduced that you are a nephrologist, which is a person who specializes in the medical treatment of kidney diseases. I think some people know about a urologist. That's somebody who does surgical treatment of kidney disease.
Structural.
Right. Yes. So I just want to distinguish that, but you have our specialized treatment in kidney diseases related to chronic kidney issues.
Sure.
Great. So start off by telling us, what does the kidney do?
Kidneys are basically the filtering units in our bodies. So they filter all the waste products, which we and fluid. They're basically bean-sized organ, like almost the size of a fist. That's in the back. It's just below a rib cage, and you normally can't feel it. But there are two in each person, and they are in the back that you can feel them. There are a couple other things the kidneys do. In addition to filtering the fluid, filtering the waste products and the fluid, they also control or make hormones that that help make the red blood cells, like erythropoietin. So when we develop kidney disease, we can develop some anemia. It also controls the bone health and high blood pressure by making certain hormones in the kidney.
It's a busy organ.
It is a busy organ.
So you said controlling fluids, controlling blood pressure, controlling some bone health issues, and anemia. And anemia issues all play a role in the health of the kidney. So if the kidney's health is good, those things are in good situation. Yes. But if the kidneys are not, it can affect those things.
Yes.
Okay. So just help me understand then, in general, how can someone know if their kidney function is okay? Sometimes a patient will say to me, I make a lot of urine, my urine is clear, and therefore I must be fine with my kidneys. Is that a good assessment that patients can have?
Kidney disease per se is a very silent disease. You have to lose up to 80 to 85% of your kidney function before you get any symptoms whatsoever. So it is a silent killer. So hence we need to screen people who we think are at risk to develop kidney disease. People with even 60%, 50% kidney function may feel just normal. They will have normal urine output, they'll continue to feel fine. Hence there is a push to screen patients for chronic kidney disease now. So just because you make normal urine and you feel well doesn't mean you don't have kidney disease. You could still have it.
So you said two things I'd love to cover in there. You said if you're at risk for kidney disease, and you also said there's a screening method.
Yes.
Let's take either one of those first, but let's start. Who would be a person who cares about their health, is seeing their doctor regularly? What medical problems, or are there certain racial or ethnic groups that people should worry more about kidney disease?
Sure. So diabetes is the #1 cause in the country for people who develop kidney disease down the line. And often you have small amounts of protein leaking in the urine. That may be one of the earliest signs in diabetics that they will go ahead and develop some kidney disease. Hypertension is the second leading cause. There are a couple other things that can cause chronic kidney disease, which we define basically when you've had progressive decline in your kidney function now over 3 months. So such things are certain hereditary disease like polycystic kidney disease. Sometimes like a strong blow to your kidney or trauma can cause some chronic kidney disease. But basically hypertension, diabetes are the #2 causes. Also with chronic stone disease, if you've been using Motrin, Aleve, Advil, any of the NSAIDs for a long time, they can cause some chronic kidney disease as well. So these, I would say, are the high-risk people that should be screened definitely for development of chronic kidney disease. Now, how would you know you have chronic kidney disease? So there's a simple blood test your doctor can do, and it's the serum creatinine. Serum means in the blood. So you're basically checking this level in the blood. And normal is anywhere between 0.7 to 1.2, 1.3. So your level may be 1.3, but just because you have a level of 1.3 doesn't mean you don't have kidney disease. So there are wide variations in this number, often depending on your muscle mass. So clearly the first test your doctor could do is just check a blood creatinine level. And once we see, usually a creatinine over 1.3, 1.4 will signal them that you have some chronic kidney disease. At that point, your doctor can do a couple other things. They can first of all do a simple test in the office. It's called a urine dipstick, and they can check for protein in your urine or blood in your urine. If we see any of these things that even adds more, that needs further investigation, which can be done with a simple renal ultrasound or a kidney ultrasound to begin with. And we recommend a basic renal ultrasound to first of all assess that the structure of your kidneys, to confirm that in fact you have two kidneys. Some people are born with one. And then to make sure there is no obstruction, that means the urine is flowing from the kidneys to the tubes that connect it to the bladder easily, and there are no stones or masses or any cyst in your kidney.
Let me just interrupt briefly just to review some of the things you said, because it's a great amount of information, and let me just review it for our audience. So you said to start this conversation, the people who should most be worried in our audience about thinking about kidney disease is something that should be on their minds are patients with high blood pressure, diabetes, people who have had kidney stones, or people who have used the drugs for arthritis, the non-steroidal drugs like ibuprofen or Advil for a long time. Those four groups.
Yes, most commonly, yes.
And then you said that there's an easy blood test, which is very available. It's actually done quite commonly. It's nothing special about it, called the creatinine, that can give us an early evidence of a problem with the kidney. Is that, I think, a basic way we can start with that?
Yes, yes.
Can we just talk a little bit about understanding how that works, that creatinine? What is that about? Like, what is creatinine? And is it a high number or a low number? Help us understand that a little bit.
So creatinine basically a byproduct of our muscle metabolism. We all generate some creatinine as we go through our day-to-day activities, and it depends on our muscle mass. So if so as I said earlier, the range is roughly from 0.7, 0.8 to 1.2 to 1.3. Clearly, a creatinine of 2 is abnormal. And so when I say a number, so the caveat or the problem just relying on your serum creatinine alone, it's a good screening test, and it's probably the one that's used most commonly, is that it can vary tremendously just based on your muscle mass. So somebody who does a lot of workouts, is maybe taking creatinine supplements, has got a lot of muscle mass, his creatinine could be 1.4, 1.5, sometimes even 1.6, but that does not mean he has kidney disease. And just if we relied on this number alone, that would raise a lot of false alarm, and we often see such patients. The other caveat could be patients who are very sick, malnourished, liver disease, just very thin. Even in pregnancy, your creatinine can be falsely low. In somebody like that, a creatinine of 1 is kidney failure. So what can your primary care or your physician do to discern that you in fact truly have renal insufficiency with not relying solely on your creatinine is calculate what we call as GFR, or glomerular filtration rate. Now, glomerulus is the basic unit in the kidney. And what this rate adjusts for is race, your muscle mass, and your age. And that number sort of helps us decide how much your kidneys are working at. And for most part, in the early stages of your kidney disease, your primary care could take care of you. But when your kidney function or your GFR has started to drop less than 60, that time it's prudent to see a nephrologist or a kidney specialist. And we recommend that.
Great. So I think I understand that better now. So thanks for that explanation. So if you're a muscular person, your body's going to make more of this creatinine. It's going to be in your blood. The kidney's job is to get rid of that. If the kidney's not functioning well, that level will be higher when we measure it in your blood. And then on the opposite, if you're, say, an elderly person without a lot of muscle mass, a more frail person, that person will have less muscle mass, so they're making less creatinine.
Hence filtering less.
So therefore, their number should be lower. So if it's even a little bit high, it could be definitely abnormal. So that's the issue about the creatinine, and we can figure out a way around that by using this calculation.
Called as GFR.
Which takes into account the patient's age and their weight, and that helps doctors figure out whether the creatinine is, even if it's a little bit out of range, is worrisome or not worrisome.
Exactly. Absolutely.
Okay. So that's great. So thank you for explaining that. So then, once someone has started, say they're not really worrisome, but it's enough that we do this calculation, and it is definitely abnormal. You mentioned that the doctor will then go into some testing to see why is it abnormal. Like they'll look at the urine to see if there's blood or protein. They'll do an ultrasound of the kidney. So those are basic levels. But if all that checks out basically okay, is there nothing left to do? Are you just left to go on to bad kidney failure, or what can be done for the patient then?
So again, before I can explain this better, so we divide chronic kidney disease, which is progressive kidney failure or decline that has lasted more than 3 months now, into 5 stages. And so stage 1 is basically when you have some kidney damage, but your kidneys are functioning normal. This is a lot of our patients who are seeing their primary care doctor, so they have small amount of protein in their blood, small amount of blood in their urine, or protein in their urine, or so they have cysts or stones, but the kidneys are working 100% of what it should. You basically don't do anything here. You just look at the risk factors and you try to modify them. Then comes stage 2 chronic kidney disease, where now your kidney function is roughly between 60 to 90% or 89%. Here you may have some mild hypertension. You're now starting to leak a little bit more protein, but for most part, you may feel great. Your kidneys are working fine. And at this point, maybe your doctor may want to add some blood pressure medications, control your lipids better, and so forth. When we get involved, or when a kidney doctor gets involved, it's typically when your kidney function has declined below 60%. So now it's between 30 to 60%. And that's when there is a push nowadays more and more to make early referrals to a kidney doctor. And why it's important to see a kidney specialist at this stage, because now your kidneys are only working 30 to 60%. Hence, your blood pressure could be an issue. You can now just start to develop anemia. Your bone health, so your vitamin D levels, your calcium level, your phosphorus levels can be affected from your kidney disease. And your blood pressure needs to be monitored better. At this stage, we want your blood pressure to be less than 130/80. If you have diabetes, we want your hemoglobin A1C to be less than 6.5 or even 6, based on some guidelines now. So we want to, basically at this stage, you want aggressive risk factor modification and prevent people from progressing further. And they've shown people who were followed by nephrologists had delay in their progression to more severe or advanced kidney disease. Then stage 4 kidney disease is when your kidneys are functioning roughly between 15 to 29%. These are the patients who absolutely need to have a kidney doctor, because now their creatinines are up to 2. They are starting to feel just slightly sick from their kidney disease. As I said earlier, you have to knock a lot of your kidney function before you start feeling sick. So here the patients are having loss of appetite, nausea, not feeling well. Their blood pressure control is getting harder and their blood counts are lower, and they may need certain agents such as erythropoietin or Procrit to artificially boost their blood counts. And also they may need agents like vitamin D or vitamin D analogs to control their calcium and phosphorus levels better. And this stage, absolutely why we need to see them is they are getting closer and closer to needing what we call as renal replacement therapies or dialysis. And we want to educate them better and prepare them better if and when they need dialysis. And the last stage of stage 5 kidney disease is end-stage kidney disease, where they need renal replacement therapy as a life-sustaining therapy, where they will need dialysis, either hemodialysis or dialysis through blood, or peritoneal dialysis, or a renal transplant or a kidney transplant to sustain their life.
So that was a ton of information. Thank you for that. Let me just review
Sure.
some of that to make sure. So for our audience, we talked about how we start this process by being worried about the kidneys and we
Sure.
get them evaluated. So we did the creatinine and the testing with that calculation we talked about called the GFR to see if they truly are problems. You did a beautiful job taking us from there all the way down to permanent, irreversible kidney damage. But we obviously don't want to get there.
Sure.
So you talked about some strategies. So I'd like to focus, if I could, and we've on this program many times talked about preventive strategies for
Sure.
heart and vascular disease. So let's just take a few minutes, and I think you went over that well, but let's just review it.
Sure.
Because at the beginning you said 2 groups that were at risk were the high blood pressure patients and the diabetic patients. And I want to just review, because I'm not sure everyone knows those terms, the hemoglobin A1C and the systolic blood pressure.
Sure.
So let's review that if we could. But you also mentioned this thing about protein in the urine. So what I tell patients, and I'd love to have you correct me if I'm wrong, but I tell the patients the kidneys are like a sieve. When we were children, we played with a sieve in the sandbox, and we let the sand go through the sieve, and the rocks are supposed to stay in the sieve. But if the sieve is broken, the rocks will fall into the sandbox. And that's what we don't want. We don't want the protein to go into our urine because protein is very valuable to our bodies. We need to save it as much as possible. So an early way to identify that the kidney sieve or filter is broken is that there's protein in the urine. So I'd love to talk about, if you could focus on the blood pressure, the diabetes, and that protein situation that's going to prevent us from going all the way to needing dialysis.
So basically, what can we do to prevent chronic kidney disease once we have it? As I said earlier, once you have an elevated creatinine or your GFR is low, one of the easiest or the first tests we ought to do is a simple urine analysis that can be done in the office. And if it's dipstick positive, even if it's not dipstick positive, we want to check for what we call as microscopic proteinuria or microscopic amounts of protein in your urine. And we can best do that by obtaining a spot urine protein to creatinine ratio. What does that mean? That means that you could just give a few drops of your urine, and we can run this test. We don't need to do a full 25 urine collection as we used to do in the past. And we take a ratio of your urine creatinine and protein. And if the number is over 30, that means you have some microscopic amounts in your urine. If it's over 300, then it'll be dipstick positive. But what we are trying to catch is people who are between 30 and 300, because there has been a correlation between microscopic proteinuria or small amounts of protein in your urine and heart disease and overall health. So what can we do once we detect protein? What should our next steps be? So basically, at stage 3 or early chronic kidney disease, our goals are to control your blood pressure better. So we aim for blood pressure less than 130/80. And how do we achieve it? We absolutely want patients to be on a category of drugs called as ACE inhibitors or angiotensin receptor blockers. And you may be familiar with some of these medications like lisinopril, Diovan, and so forth. And what they do is they protect your kidneys in the long term and also good for your cardiac health. And they help decrease the leakage of protein in your urine. Other things that you want to do is definitely control your diabetes better, control your lipids better, weight loss, and so forth. So our goals at this stage are risk factor modification. These are the modifiable risk factors. There's some risk factors that are non-modifiable, like your age. If you are over 65, you have a high risk of developing chronic kidney disease. There's certain races that are more prone to develop chronic kidney disease, such as African Americans. They have a lot higher incidence than the Caucasian population, Asian Americans, Hispanics. So we're seeing not only that chronic kidney disease is more severe, they just have a higher incidence, and it's often difficult to control their blood pressure and so forth. And these patients are developing a lot earlier to end-stage kidney disease and needing dialysis. So again, identifying these at-risk population and being very aggressive with risk factor modification is our goal, and that's why early referral is key to a kidney specialist. So we can sort of delay the course of the kidney disease. What I tell patients is once you have chronic kidney disease, you have it. There's little you can do to reverse the changes that have already taken place in your kidney. It's like going down on a slide. You are going to go down. Your endpoint is dialysis. What our goal is to keep you on the top as long as we can and slow the decline in your kidney function. It's hard for a physician to reverse. We can reverse some of the changes that have happened, but we can definitely slow the decline in your kidney function and maybe prolong the time before you need dialysis and prevent it if possible.
So you did a great job, and thank you for reviewing the things that can cause the kidney function to start and get worse. Blood pressure, sugar, and the protein issues are things that can be monitored easily by any doctor. Primary care doctor, kidney specialist, cardiologist can all monitor these things to all work as a team to help the patient get these numbers as optimal as possible, with the hopes that, as you said, the slide, instead of being a steep slide, will be a more gradual slide. But earlier you also talked about how the consequences of the kidney issues can cause other problems. So if we could talk about those, you mentioned 3 things. You mentioned anemia, which is a low blood count. The red blood cells are the oxygen-carrying blood cells of our body. So that's an anemia, and it's measured with a blood test called the hematocrit. You mentioned about bone health, and vitamin D and parathyroid play a role in that. And you mentioned blood pressure. So let's talk about those 3 consequences of kidneys as something that a nephrology specialist would follow patients for.
So all of these things that Dr. Bilazarian mentioned can be seen as soon or as early as early stage 3 chronic kidney disease. Clearly, these things get a lot worse as we progress to the stage 4, where your kidneys are now functioning less and less. And our dialysis patients, for most part, end up needing multiple agents to correct it. I'm going to walk down each of these things individually. So anemia is basically a drop in your hemoglobin or hematocrit, and hemoglobin less than 10.
So a normal number is around
10.
13 or 14,
Yeah.
so 10 would be a low.
10 would be where we would start treating them with erythropoietin. Those are the Medicare guidelines. So when the number has started to decline less than 10, we want to make sure there's nothing else besides the chronic kidney disease that's driving it. So we do a battery of tests, and we check their iron levels, their vitamin B12 levels, their folate levels, and we make sure these levels are adequate. Once we have these levels are adequate and we don't think they're contributing it, then we suspect that their chronic kidney disease is what's driving their blood counts to be low. At which point, we give them agents called as erythropoietin, which can be administered in the office setting. And it's given subcutaneously and can be given by a nurse. So they see the nurse, they get it, for most part, every 2 weeks. Some people need it every week, some may need it once a month. And that helps to boost their blood counts.
And basically, that's just the same hormone that a healthy kidney would be making.
Exactly.
So our kidneys, my kidney's healthy, so my kidney releases a hormone like Procrit or Aranesp or erythropoietin.
Yes.
And it circulates in the body and tells my bone marrow to make more red blood cells.
Exactly.
If my kidney didn't work, I wouldn't release that hormone,
Sure.
so there wouldn't be a message to make more red blood cells, so my blood count would go down. So the way the kidney specialist helps is by giving it a shot of this hormone that tells the bone marrow to make more red blood cells to help correct that anemia or raise that blood count up.
And so not only does it correct your anemia, the quality of life indicators are so much better in people who are on it, because they're now not feeling uremic symptoms or not feeling lousy, nausea, and so forth. And they're feeling better. They just, their quality of life is so much better when they're on these agents. The second thing is hypertension. Now, hypertension could be worse in a setting of chronic kidney disease, and there are certain hormones like renin that's made by the kidney that can contribute to it, or just because of scarring of your blood vessels and so forth. But basically in kidney disease, you can have a lot worse hypertension. So clearly some of the agents that we need to have our patients on are ACE inhibitors and angiotensin receptor blockers, and often we put them on a water pill as well. Some of our renal patients can often need 3 to 4 or even more antihypertensive agents because they have very severe hypertension. And there are a couple other things that we do even just beyond treating them for what we call as essential or normal hypertension. We screen for other things such as stenosis in the arteries or these hormone levels if we're having issues treating the high blood pressure. And the third thing is their bone health. So it can affect their phosphorus levels and also the parathyroid hormone levels.
Let's tell us, though, why that is, because you did a great job explaining why people get the low blood count because of this hormone.
Sure.
Explain what's the connection between the kidney and the bone?
The kidney and the bone. So kidneys, the vitamin D is converted to an active form in the kidney. And also kidneys control the calcium and the phosphorus levels, which affect the parathyroid hormone levels. Now, parathyroid glands are these tiny little 4 glands that sit behind the thyroid gland that make this hormone called as parathyroid hormone. In patients with kidney disease, this hormone is elevated, and it then affects their bone health and their phosphorus levels. So what we do is we measure their parathyroid hormone level, and we also check the vitamin D level. And based on how severe your kidney disease, your parathyroid hormone, we have a gauge. So even if it's elevated, it may be appropriate for the level of your kidney disease. If it's higher than that level, then we treat them with vitamin D analogs.
So just to make it simple, the parathyroid hormone elevation causes calcium to come out of the bones, making them weaker.
Yes.
So that's the thing we worry about.
Yes.
Okay.
Yes. And also your phosphorus levels are higher in these patients.
Okay. So the parathyroid hormone is accepted to be a little bit, but if it's too high, we try to keep it down
Lower.
by giving more vitamin D.
Which shuts it off. And there are various other medications too that can be given, such as Sensipar or the medications that we give patients with dialysis that can target this hormone as well.
And are there any other things that you would want to share with us? We're in our final minutes of our program on
Sure.
chronic kidney disease. We've talked about being attentive to it, recognizing it with the creatinine. We talked about strategies to prevent it from worsening. We talked about at-risk groups, diabetics and hypertensive specifically. We talked about treatments for prevention and then consequences we've just been discussing right now. Are there other topics in the final minutes that you would like to share with our audience about chronic kidney disease?
I think the key thing is when you have chronic kidney disease to make sure you take your medications. Be very astute when you go to your doctors. Keep an eye on your creatinine. I think it's good to know what the trend in your creatinine has been. What I tell patients is often they are on multiple medications such as lisinopril, which is an ACE inhibitor. They're on a water pill, and then they say fall sick, and then they start taking Motrin Relief, Advil, or any of these medications for pain relief. And what can happen is that can push your kidneys into what we call as acute renal failure. So if you are sick for any reason and you are on some of these medications that I mentioned, like a water pill, some of these blood pressure pills, it may be prudent to call your doctor right away, or just maybe stop these medications if your blood pressures are low, because that can affect your kidney function. And a lot of times patients forget to stop these medications when they're sick. So it's key to know that some of the medications you take depend on your level of kidney function. Also, if you get started on a new antibiotic, always ask or tell your doctor I have chronic kidney disease, because it may need to be dose adjusted. But just being more aware of your kidney disease and making sure you take your meds and being, sort of keep a closer eye on your creatinine and your urine protein would help.
Yeah, I think that's a fantastic and comprehensive review of chronic kidney disease, recognition, treatment, prevention. It's been fantastic having you with us today on Matters of the Heart. Thank you for joining me. And I think that hopefully the audience derived great benefit. I'll reemphasize something Dr. Nadkarni said at the beginning of this. This is not something that you can feel. We've had many programs on Matters of the Heart about high blood pressure and cholesterol and other things that are really silent. You can go about your business and not have any kind of issues and say, I feel fine. But the early recognition of this particular problem that we're talking about today, chronic renal dysfunction or chronic renal failure, is really valuable, because ultimately avoiding the slide to end-stage renal disease is wonderful if we can delay that as long as possible. Hopefully delay it so it never happens, but delaying it as long as possible would be ideal. And there are some very effective strategies for prevention. So I thank you again, Dr. Nadkarni, for joining us. And I thank you for joining us on this program of Matters of the Heart. Until next time, I ask you to see us again here on Matters of the Heart. I'm Seth Bilazarian from Haverhill Community Television and Pentucket Medical Associates. Thank you.